Warm welcome to our education event this evening, which is an OrthTeam sports-related concussion event. And we're going to run through some aspects of the Amsterdam International Consensus, and we're going to discuss some cases which hopefully will be of interest. Just to say that the event is being recorded this evening for education purposes, and only the talks that we're giving, the question and answer section at the end, will not be recorded. So please do put questions in the chat function, and we will address them at the end if that's okay. There will be certificates after the event, CPD certificates, and there'll be a SurveyMonkey questionnaire which will be sent out, and we'd really welcome your feedback on that. Just to kick off, just bear with me a second. So these are the publications in the British Journal of Sports Medicine from June this year, and these were the culmination of 4 or 5 years of work and over 80,000 articles that were sifted through, and the ones that were actually reviewed to pull together answers to 8 systematic reviews. And these build on the previous international concussion conferences from 2001 and every 4 years thereafter. And there's a huge amount of work that goes into producing these statements. And as you know, it brings together a concussion in sport consensus statement, which informs our practice. I would really highly recommend, if you've not done so already, getting into the detail of these documents, much of which is freely available online. So this is the consensus statement on concussion in sport, and I'm just going to set the scene, run a video which hopefully will help summarize and get our minds in the gear for what we're talking about this evening. So that's a nice piece of work by BJSM there in summarizing that in that video. And as I say, this is freely available online if you haven't read through it already. So just a brief update on the concussion clinic that we offer at the OrthTeam. There's several of us involved in this. So Jim, my colleague, who's a consultant in sport and exercise medicine, Martha, who is a physiotherapist locally with a specialist interest in concussion, Mark Kellett, who's a consultant neurologist with an interest in concussion. And we are in the process of pulling together a regular concussion MDT so that we can discuss more complex cases in a multidisciplinary team format. As you know, these cases can be complex and contentious with regards to return to sport, and sometimes there are difficult and ethical decisions to be made. There's various other wider MDT members. We work with a group of neuroradiologists. John Leach and Anchor Saxena are two neurosurgeons who I work closely with here at OrthTeam, who are mainly spinal neurosurgeons, but also John has particular experience working in concussion. Jane Thistleton and Kathy Gordon are both vestibular physiotherapists with relevant experience in vestibular rehabilitation. Alan Johnson and other colleagues from a consultant psychiatry point of view. Dan Nolan is a consultant ophthalmologist who helps with some of the challenging oculomotor cases. Farouz and Aoife are clinical psychologists who we work closely with, and then Hobbs Neurological Rehab Services are probably the biggest independent rehab service for concussion nationally, who I've referred several patients to, and I know Jim has through the UK Sports Institute. So the agenda for this evening, Jim's going to kick things off by talking about the SCOT-6 and assessment of persistent symptoms and targeted rehab. And then that will move on to Martha, who's going to talk about modified VOMS assessment, exercise testing and rehabilitation. And then I'll finish with talking about later in life risks following sports-related concussion and repeated head injuries and retirement. And then we'll have hopefully time for 10 or 15 minutes of question and answers at the end. So on that note, Jim, I'll stop sharing and hand over to you.
Thanks, Sean. Just going to work out how to share my screen here. Okay. Okay, hope you can see that okay and hear me okay. Yeah, my name is Dr. Kerss, consultant in sport and exercise medicine. I work with John at OrthTeam Centre. Very grateful to the team at OrthTeam for putting on the event tonight and for everyone for turning up and giving some time on a Wednesday evening to join. A little bit about myself and my personal interest and background with concussion. I've been working in sports medicine for just over 12 years now, and seeing concussion cases through a variety of sports, including rugby union, rugby league, football and netball, where I was a netball doctor for 6 years. So developed a particular interest in seeing females with concussion. And nowadays, I have three main areas where I'm interested in concussion. One is through my work as sports medicine lead at the UK Sports Institute, where I sit on the brain health strategy group. So we're in charge with setting UK Sports Institute guidelines for management of concussion in sports that are funded by UK Sport across Olympic and Paralympic sport. And I'm also a team doctor for EF Education First Pro Cycling Team. So we get a fair amount of riders unfortunately fall off, sustain head injuries. And the challenge with these athletes is they can be based all around the world. So we do quite a lot of concussion management remotely, as well as with non-native English speaking athletes as well. And then lastly, privately. So via my private clinics, OrthTeam particularly, and Spire Murrayfield Hospital, I see a variety of elite athletes and non-elite athletes who have had problems with head injury related to sport. And that tends to fall into different categories. Sometimes now they're coming for a SCOT-6 assessment, sometimes for an assessment prior to return to play, sometimes because they've got persisting symptoms, and also sometimes for discussions around retirement and recurrent concussions as well. So it forms a variety of different things. This slide really is just talking about concussion. It's a really spectacularly interesting area of medicine at the moment. It's a really challenging area, really emotive area, full of opinion. This is just a clip here that looks at the number, if you type in concussion into PubMed, the number of publications that come up, and you can see, over the last 7 to 8 years, it's hugely rocketed in interest from a research point of view, and that was put across from the consensus statements with the huge amount of information and papers that they had to go through. I would say that the research and clinical practice hugely developing. So how we're managing and assessing concussion now, I suspect, will be hugely different in 10 years' time. And if you look back 15 years or so, or almost 20 years now, back in 1995 there on the chart, there was only 90 odd papers being published a year in concussion. And some of the research that came out of the Amsterdam consensus statement actually did a review and looked back at the average return to play for athletes back in the 90s. And there were some stats showing that 30% of athletes sustaining concussion returned to play on the same day back in that era. So you can see how much things have changed. And it's one of the areas in sports medicine, I would say, where we're in a lot of different injuries trying to reduce down the return to play time, but actually in concussion it's going completely the other way, is that we're trying to extend out concussion and have a much safer approach. That's for a variety of reasons, because of developing understanding, but also there's obviously the I think lawsuits going on that have previously happened in America, currently ongoing in the UK as well. It's interesting to look at the law firm who are in charge of this saying, will you be targeting individual clubs and medics? And they say, no, not yet, which I find slightly concerning. And again, also, it's just a warning there, just to err on the safe side, I would say, with management at the moment, because we don't know how things are going to go with future understanding of brain health and concussion management. And the last bit on this slide was, this was the output from the consensus meeting, where they asked people future direction of desired research, where people wanted it to go. And you can see there that there's a huge amount of interest, particularly in potential long-term effects of concussion. So definitely watch this space, and be really interested to see how things develop in the years ahead. So what we're saying now on the presentation, I suspect if we're still doing the same thing in 10 years' time, it'll be vastly different. So my proposal aims as to what we're going to talk about. I'm just going to move this camera over here. Is the first bit is to do with the SCOTE 6, bit of introduction and background to it and how it actually works in practice. And then the second thing is talking about athletes with persisting post-concussive symptoms, with considerations for assessment and management. And we'll talk through a case at the end as well. The SCOTE 6, so that stands for, the O is for Office Assessment Tool 6, which goes in with the SCAT 6. So you might ask, why was this developed? So when you look through the research about the different iterations of the SCAT, it's only been shown to be particularly reliable up to 72 hours following a head injury for diagnosis, and has never been validated as a tool for serial monitoring or continued assessments of athletes who have suffered from head injury. And the SAC component of the SCAT can't distinguish reliably from concussion from non-assessment between 3 to 5 days post-injury. So there was a definite need to develop something after that 72 hours period of time to help with a more robust assessment of athletes who have suffered from concussion. What the SCOTE 6 is, it's a multimodal serial clinical assessment that's done in the office setting away from the pitch side. The research, when they developed this, where they took research that was looking at assessments of concussion from the 72-hour mark through to 30 days post-injury. They say in the statement that you can use it after 30 days, but there's been no research that's been published or used in that assessment. So that's at your own risk. It's developed by the consensus statement from the research group, and any healthcare professional can use it. It's not necessarily just designed for a doctor to use. The thing I would say is, from all the research, it's a proposal from a consensus. It's not yet been validated and actually research proven that it's effective or any better than what's out there already. It's just been something that's been proposed from the output from the concussion consensus group. And there is a different version for children, so 8 to 12-year-olds with a child SCOTE 6. These are the areas that it looks at. So I've tried to put these into as simple terms as I can do, looking at blue, so it's the first assessment only in the first column, green, which is recommended that you do at the SCOTE 6, and also orange, which they say are optional as well. Okay, I would suggest when you start doing these, if you're doing them in clinical practice, is to give yourself minimum an hour to start with. I allow an hour for these patients when I see them in clinic. And it definitely takes that long, because they're pretty robust and in-depth assessments. The blue one on the first assessment is obvious things like current injury history, previous history of head injuries, and a history of past medical history, including neurological, psychology, psychiatric, and learning disorders. And the green recommended sections, there's quite a few things from the SCAT-6, such as symptom evaluation, which you'll recognise, and different assessments, including verbal cognitive test recall, digits backwards, and months in reverse order. They've now changed that to 10 words from 5 words as a standard, and you can also increase that up to 15 as well. The bits in red I'll touch on in a second, but you have the orthostatic vital signs. So that basically means assessment of heart rate and blood pressure, both lying down and then standing up after 1 minute, an in-depth cervical spine assessment, modified VOMS assessment, which I know Martha's going to be talking on. The orange optional areas, you have a bit more detail on family history, 15 words we talked about, the graded aerobic exercise test, which refers to the Buffalo concussion treadmill or bike test, computerized neurocognitive assessments, which can be things like impact, sleep assessment, depression and anxiety screen, and also the new tandem gait tasks, which are the complex and dual task gait as well. These are the links to the papers if you wish to have a read through in more detail. I definitely suggest doing so. The bits to highlight around symptoms that they touched on in the research, which I think is worthwhile bringing up, is the most common that we've seen now from the ratings here: headache, head pressure, photophobia, phonophobia, and just saying that the athlete doesn't feel right. It's worth having a look out for these ones. So headache severity and frequency, confusion, forgetfulness, attention difficulties, trouble remembering, getting tired, and dizziness. All of these in the research have been shown to be associated with potentially longer duration of symptoms. And also definitely watch out for athletes with high initial number or total severity symptom score, because that's been shown pretty consistently in the research to be associated with longer recovery times. Use 15 words if the athlete's finding the 10-word recall easy. And the computerized neurocognitive tests, everyone's got a different opinion on these, but the research does say that they may help differentiate concussed versus non-concussed, but it's not really clear which measures within the neurocognitive assessments on the computer may help. Things like reaction time have been mooted, but not consistently shown in the research. I would say from my own experience of using the computerized neurocognitive test is just make sure that you counsel the athlete accurately on making sure they've got enough time to actually do them, and understand that they can be a lot more taxing mentally compared to doing a SCAT-6 assessment on the athlete. Normally 30 to 40 minutes I would allow. Make sure that as a healthcare professional, you've got training in the interpretation of these tests as well, and you've also got the athlete and sport buy-in before you implement those things. And lastly, just make sure it's not a standalone method of diagnosis, so you're not relying just on the computerized assessment alone. From a modified VOMS point of view, again, researchers said it can help confirm a diagnosed concussion. Just practice with the assessment of this. And if you're unsure, if you spot something you're unsure of, I would just recommend seeking specialist assessment and opinion on this. From an autonomic nervous system point of view, just be aware that the symptoms and sign of this may still persist at return to play or return to sport. So it doesn't have to be something that returns completely back to normal when you're returning an athlete to sport, just as long as they're able to return back to their sport safely. And the management of this really is by graded exercise. So consider doing a Buffalo concussion treadmill test and increasing the exercise appropriately. The other things that can help is vagal nerve stimulation and other things such as meditation, breathwork, and yoga I've found to be successful in those areas. Modified BESS we talked about. If you don't have baselines for your athletes, it's been reported in the research that 4 hours in total is the cutoff point for this, is what would be deemed normal for a population. And the GACE assessments, I would say we've done educational videos on these within the UK Sports Institute because they can be relatively complex. So definitely practice them first as a team away from the athletes before you're using them in the flesh. And ideally, I would say compared to an athlete's baseline on these or population norms, which are within the research papers that I put up before. I'm going to talk now on persisting post-concussive symptoms. So this is a particularly challenging area. It's been reported in the literature a huge range of potential percentage of development of this. The highest figure I've found in the research was up to 30%, and that's what's often quoted in most of the papers if you look into this. Previously, it was defined before the recent Amsterdam meeting as 2 weeks in adults and 4 weeks in children, but they've changed that now to more than 4 weeks across all age groups. And the important thing I would say with this is it doesn't have to be directly concussion-related symptoms. So what we talk about here is that the persistent post-concussive symptoms can either be related to the concussion and the head injury themselves, or they can be pre-existing symptoms that have just got worse as a result of the concussion, or they can be a mixture of both. And that can be the real challenge when you're seeing athletes weeks or months down the line, is trying to unpick how they were before the head injury and trying to unpick whether this was pre-existing condition that's got worse, or whether it's directly related to the concussion, or both. In my own personal belief as well is that just consider this earlier in the elite, so in the elite athletes. So if you've got these athletes just non-improving by 2 weeks, then just consider having a look at this, the things I'm going to talk about, a bit earlier than 4 weeks. Just remember that the consensus statements that were done were not targeted solely at elite athletes, they were done on a population level. So just consider bringing forward that consideration of, is this athlete developing persistent symptoms to 2 weeks? That's my own opinion. This was one of the papers that looks at all the different things that have been researched into see if you can identify an actual diagnostic test to find if someone's going to develop persisting symptoms or not. And basically, from all the orange bars being all the way over to the left side, you can see that there is no definitive accurate test that's as a diagnostic test that's been found. So what the recommendation is, it's basically a multimodal, multidisciplinary team assessment is recommended in these athletes when they have persisting symptoms. And as I said, focus on the difference between pre-existing symptoms and medical issues versus post-injury symptoms as well. I put down here and tried to dig through all the research that's out there as best as I possibly can. And I may have missed some stuff, I admit this, but this was as much as I could find on the possible risk factors, because it's always nice as a doctor or physiotherapist or healthcare professional looking after these athletes to say, am I going to keep a real particular eye on this athlete to know whether they may develop persisting symptoms and may not recover as fast as I would like. I've tried to split this down into whether pre-injury, if they're known to report more symptoms. So as in, are these the people when you do your baseline, they flag themselves up as having symptoms on a regular basis anyway. Pre-injury risk factor and also post-injury risk factor, and that refers to head injuries. So the research shows that there is a difference between reporting of symptoms at baseline between females and males. Females more likely to report baseline symptoms, also in ADHD and also in athletes with learning difficulties as well. Pre-injury, the two papers here were the big ones that I looked at, and there was a definite difference here between the paper published in 2017 and the more recent one in 2023. Originally, it was felt that being a female carried an increased risk of persisting symptoms and delayed recovery. The most recent paper in 2023 suggests that isn't the case. I would say go in and have a look at the data, because I know from the UK Sports Institute data that we look at, females do have a longer return to play time. And if you actually look at the data and dive down into the number of days, it's different. It just hasn't met statistical significance in the research papers that they've looked at for 2023. So I would say, from my point of view, looking after elite athletes that I do, when you look at the return to the recovery times, there are 3 days difference between female and male. So 9 versus 12 days, male versus female. And then also the same thing when you look at our actual return to sport times, they're also different by 5 days. So I would say personally, looking after elite athletes, it may be slightly different on a population level, like these research papers were done. But I would say looking after elite athletes, the difference between 3 and 5 days for return to play and recovery of symptoms is definitely significant. But that's, again, my opinion, and that's why I put that in amber. Previous studies have also shown that teenage years, getting head injuries there might be a risk factor for persisting symptoms, but that has been put in the recent paper not to be the case. Fairly consistent is previous history of depression, migraine, and anxiety. And again, amber is prior concussions, because that was shown in 2017, but not 2023. But I've kept that in just because it's something that we look at in athletes, and we never know how the research is going to change and evolve. In terms of post-injury, the thing that comes up really significantly here is the initial number and severity of symptoms after the head injuries. I couldn't find any specific actual data to say a cutoff, so just be aware of those athletes when you're doing the symptoms and they're scoring all the way across in the 4, 5s, and 6, and you have very high severity scores. Just keep a very, very close eye on those athletes, I would recommend. Again, from the previous research before 2017, sleep disturbance, headache, and depression were things that were flagged up, but not so in 2023. The 2023 paper came up with some new ones where if the VOMS heavily provokes the symptoms, that could be a risk factor for persisting symptoms. And importantly, if there's been a delayed removal from sport post-injury, so if the athlete suffers a head injury on the field of play and they have a delay until they're removed from playing that game, then that has a higher likelihood of persisting symptoms. So just a message for those of you involved in pitchside care, if in doubt, just get them off the field of play for assessment. And the last one is time until seen by a medical practitioner. So if there's a delay in seeing a medical practitioner following an episode of suspected concussion, again, that can lead down the route of persisting symptoms. And I would put a nod there to say the elite side of things, unlikely to happen. Most of the sports have a physio doctor on hand to see. And that's most likely why they've put in the recent community guidelines you may have seen is the recommendation to seek healthcare advice within 24 hours to get people assessed as soon as possible. This paper from 2019 looked at persisting concussive symptoms and looked into overlapping clinical profiles to try to identify a clinical trajectory. And I would say after this paper was published, I mean, it's only 4 years or so ago now, there's been a definite switch from what I've seen in the management and assessment of these athletes with persisting symptoms and trying to identify them into clinical trajectories. So you can have a much better idea as to what the key thing that's going on is and focus treatment on that. The slide's a bit busy and lots of words. So what I've done and we've done within the UK Sports Institute is try and simplify that into this model here. And the different trajectories that I tend to look at personally for persisting symptoms when I see athletes is this related to the cervical spine? Is this related to autonomic nervous system dysfunction, fatigue? Is this vestibulo-oculomotor? Is it headache? Is it cognitive? Or is it related to mental health? And again, just remember some of these things can be pre-existing. And very often, and this thing doesn't show it as well as the previous diagram, but they're often overlapping and all happening around the same time. So it can be very, very challenging when you see an athlete with persisting symptoms to try and pick out which one's which. But I would say that is really, really important. The other important thing is to work alongside an MDT. So often when I see someone, you're assessing them in clinic on your own, I would make it an absolute must to put the athlete at the center of this, because it's really, really important is to get across education or reassurance and understanding of the condition. Really can help recovery. So put the athlete at the center, make sure communication between all these different parties is absolutely put to the top of the tree. So between doctor, nutritionist, physio, S&C, coach, and particularly relevant family members, I would say is vitally important. And as John mentioned in the original slides, is that very often with these athletes, we have to go to external referrals, be that neurologists, neurosurgeons, specialist physiotherapists, neuropsychologists, optometrists, ophthalmologists, endocrinologists, psychologists, psychiatrists. So you can see a huge amount of work can come out of this to try and support the athlete and the person in recovery. I'll go through a case example now, just of the type of thing that we would see both from a scope 6 point of view and also from persisting symptoms, and I'll hand over. So the case example here is a 28-year-old female pro basketball player who was hit on the head by a basketball, sustained concussion, was diagnosed by the club. And I saw her 2 months post-injury, and she still had persisting symptoms, which were mainly described as fatigue, buzzing sensation in the head, neck pain, and reported low mood as well. And they tried to progress the return to play, but hadn't been able to do so. Her past history was she'd had 5 previous diagnosed concussions over the space of 12 years and had previous depression, which had been resolved and treated, and also had a family history of concussion in the mum and sister as well. So we had a look at these different areas when I assessed her, and there were different things that flagged up. So on the mental health assessment, she had PHQ-9 and GAD-7, both of 10, which indicates moderate depression and anxiety. She had definite cognitive symptoms. She was working as a coach in her spare time and had difficulty with concentration. She was tender when you assessed her cervical spine, C3, 4, C4, 5, but no neurological symptoms. There was no headache particularly. And when you did the VOMS assessment, that was normal. Autonomic nervous system dysfunction, she did have this. So when we assessed the heart rate from standing from lying, she had a rise to 100 from 66. And that would go in with the persistent fatigue. So the main thing that she came with was persisting post-concussive symptoms, and she also had concern over her long-term brain health and recurrent concussions and whether she should retire from playing sport. Her aims really were recovery of recurrent symptoms and normal day-to-day functioning, and also long-term brain health protection. And the clinical trajectories we identified from the clinical assessment were to do with mental health, fatigue with the autonomic nervous system dysfunction, as well as issues with the cervical spine. So the management really multimodal, multifactorial, multidisciplinary, with the athlete at the center, and explanation, reassurance, and education on what's happening right at the very top. We also involved Martha for specialist physiotherapy input, Buffalo concussion treadmill test, and further rehabilitation, particularly focused on a cervical spine. She had nutritional advice, sleep management advice, advice around managing the autonomic nervous system dysfunction, clinical psychology input, and also an MRI brain given the recurrent head injuries, and NIH toolbox assessment, which also just looked at the cognitive function as well. And the progress that she went through was symptom resolution after a further 6 weeks or so of rehabilitation, mental health improvement, and the autonomic nervous system dysfunction resolved as well. She progressed through the return to play program overseen by Martha past the Black Hawks test, which Martha will go through with you. And after this, we had a follow-up review and documented in a letter an in-depth discussion around long-term brain health, about return to sport, about the risks of future issues. Eventually, she opted to return back to training for a period of time, and then eventually retired from basketball at the end of the season, but happily went back symptom-free. I'll put this slide, which I'll share with you. I'm not going to go through in too much detail because of time, but this is how I see all this mapping out. Spectacularly, as I said at the start, concussion is, in my mind, a really emotive, hot topic, lots and lots of debate, lots of different opinions on it. I try and make things as straightforward as possible in a quite confusing, chaotic world sometimes. And these are the type of things that I will look at when I share the slides after the presentation. You can feel free to have a look at them, but splitting these into immediate diagnosis and management, initial management, and then assessment of persistent symptoms. And I have this in my mind and on my computer desktop just to make sure that I'm going through things, and particularly this area here. So is there no symptom improvement whatsoever by day 5? Any recurrence in symptoms through the return to play process? Any persistent symptoms at week 2? Any risk factors for prolonged recovery, which I've identified below here just from the previous slides I put up? If any of those things are the case, I normally go for an MDT review and discussion, and that's why we're formulating that at the OrthTeam Centre, because this is common. You know, you're thinking 1 in 3 of these athletes might be ending up in this situation, and then identifying the possible clinical trajectory and further management from there. So I'll share that with you so you've got that as a reference, and hopefully that will be useful. And that's the end of my presentation. Thanks for listening.
Thanks, Jim.
Over to yourself or Martha.
And Martha's going to speak next. So Martha, I'll let you share screen there. Thank you. Please do feel free to put any questions in the chat function if anything, if you have any sort of queries as we go through the presentations. Thanks.
Okay, hi guys, can you hear me? Yes, cool. Okay, so I just quickly want to just very quickly say thank you to Dr. John and Dr. Jim for inviting me to give some input into the CPD event. I was asked to talk specifically about the VOMS and the Buffalo concussion treadmill test, which I'm happy to do. And I just want to mention I'm a physio, and I've got my training 5 years ago and ongoingly so with the CCMI clinic, which is international group. They've got about 500 different clinics worldwide, and they really research based. So I will tell you a little bit later more about myself, but I think if I start the presentation, that will help. Okay, so okay, this is just to talk about the VOMs. That's the first one. And just for clarity's sake, I would like to just mention that however awesome the VOMs and the Buffalo Concussion Treadmill test are for tools within your scope of expertise, they only make out a small portion of the battery of tests and tools that I or we as healthcare professionals that's trained by the CCMA Concussion Management Group use to diagnose, manage, and also rehab concussion. Currently, we have many different tools, easily about 30, in testing acute and also PCS cases, and also baseline testing, doing baseline testing. On the first acute visit, the aim is always to consider any red flags and for neck and skull fractures, and follow the Canadian head rule for CT scans in patients with glaucoma scales of 13 to 15 after witness a loss of LOC or a loss of consciousness. Although saying that only 10% of mild concussion cases are have loss, it's a loss of consciousness. So amnesia and confusion and suffering, all of these basically is going out to do to pinpoint red flags and to so you would do your neuro exams, your cranial nerve exams, cerebellum testing, upper lower limb exams, and other. So just really looking at red flags. So I'm lucky, especially working with Dr. John and Dr. Jim, when I have a patient, these tests has been done, so it make my life much easier. But just to be clear, a concussion diagnosis can be made by if there's a clear mechanism in the process, and also by only one symptom out of the 22 or more, obviously, you can actually make it is a concussion until otherwise proven. Saying that as well, whiplash, which we're going to talk about cervical stuff later on, so it's very close in symptoms with cervical with concussion, and there are ways of finding out which is which. However, it is pretty difficult to do that, to be exactly clear about that. Okay. Another concept that that's important is that you do not have to suffer a direct hit to the head to suffer a concussion. You can even fall on your bum and still suffer a concussion. So I just want people to acknowledge, not exclude people to the diagnosis of concussion because I didn't have a direct hit to the head. And then just to recap, concussion is a functional injury, disturbance, and not a structural injury. And the reason why concussion doesn't show up in CTs and MRIs. CT scans and MRIs are still needed when you want to exclude bleeding and neck and skull fractures. So please familiarize yourselves with this Canadian CT head rule for a guide to know what, when you should refer to A&E for further imaging. It's important to realize that concussion has two phases, the exutority and a creeping depression phase. I'm not going to discuss this here today, but I do want to basically mention that it is a sharing of grey matter caused by acceleration and deceleration of the brain, which causes the axon to stretch and to deform. And this is where the injury basically occurs, is in the membranes of the axons in the brain, and this causes a chemical storm of ions that exchange that causes ongoing axon potential discharge, and this will lead to an ATP deficit within the brain. And the main culprit here is calcium, as it comes into the axon and actually causes more symptoms because it's blocking ATP. Oxidative stress, and so it's blocking ATP forming or production, ATP production within the brain, and that is what you need to for the brain to function properly. The excitatory phase is what causes the athlete to be confused or off balance and blank stares as there is an ongoing within brain and an energy deficit during this time. However, when their symptoms start to reduce a few days or a few hours later, it doesn't mean that they are okay to be returned back to play, because the secondary phase has already started, although at that point you can't actually see the evidence. And this is really important to understand on club level when you deal with concussion patients. Even though they will say to you in 10 minutes later, I'm actually feeling better, don't put these guys back. If there's a mechanism and there was a symptom, they have concussion, and you have to manage them according to that. Okay. So during the recovery period, the brain is really vulnerable, and would you return someone in the recovery stage, which is, well, like we said, 30 days to recover fully, the symptoms would disappear by around day 7 to 10 in the acute concussion. And would you put someone back into sport, they would suffer the secondary impact syndrome that can result in really severe cases. There's the mortality rate currently increases really in the under 18 population of secondary impact syndrome. And we see that there's actually about 40% of concussions are suffered in schools, either on the sports field or within school. So guys, just be aware when you work with children that, about secondary, don't put guys back into sport even if they say my symptoms are gone, the brain hasn't actually recovered in full. So don't forget, when you it's really important when you do work with concussion is always to reassure your I'm talking about mild traumatic brain injuries, to educate and to reassure your patient and athlete that they will be okay and they will actually come through this whole process. Anxiety is one of the things that we find that really sets symptoms on. So that's one of the things. It's just a little tip that I can give you. It's really important to not stress these guys, even though if they have signs of a prolonged or duration of healing or recovery, don't mention it to these guys, because you will actually just increase their anxiety. Keep it to yourself, discuss it with your team members, but do not tell this to the patient itself. Okay. All right. So
Martha, sorry to interrupt you. I just wasn't sure if the slides were going forward or not, but I can see that it just has. Thank you.
Yes, it has. Okay, sorry. So, okay, so when, so just to talk about the VOMS test. So when do we use the VOMS specifically in rehab and concussion rehab? So first, I do it in the acute assessment, especially when there's no baseline. And it's not, yeah, so it can be a diagnostic tool, and with a 2-point increase in Albin in 2018, as said, there's a 50-50 chance that VOMS can actually prove a concussion or not. Everson in 2019 has done testing on VOMS in a healthy cohort of, and 89% has shown under 2% provocation with a NPC of 79%. And Bittner in 2020 did also a test where he has found that concussion VOMS isn't really an inclusive of concussion, but it's actually more a test of exclusion to show that someone didn't suffer a concussion. So the reason why we include the VOMS is because it actually does help us to understand what is going on within the patient. And it also helps us with the initial rehab and trajectory in our focus of our rehab, and also part of the final clearance process in return to sport, especially when you apply it after you've exerted your patient and then retest the VOMS. You very often would pick up abnormalities still at that point. You can often, after the final clearance with not Buffalo concussion, with the Blackhawks test, you can have up to a 30% failure rate when you go through the baseline, of which the VOMS is one of them. So just to talk about the VOMS itself, this is a full VOMS, and that is what it looks like. I will show you what the Amsterdam, the modified VOMS looks like in a minute. So just to quickly talk through it. So it's smooth pursuits. saccades, you get the horizontal and vertical, VOR, and then visual motion sensitivity, accommodations, and conversions. Each one gets scored as you do the test individually for headache, dizziness, nausea, and fogginess from 0 to 10. And then you would do a combined, you would sort of, sorry, just take a breath there for a second. Okay, so I'm going to quickly walk you through each one of them so that we just have a clear understanding what each one is. I don't know if all of you basically know how to do these, so I just thought it might be interesting to see what a smooth pursuit, for example, would be. So a smooth pursuit, you would sit 3 feet apart, the examiner and the patient. The examiner would move his fingers 1.5. So if you take midline, so you would go out with your fingers and you would actually ask the patient to follow, nose looking at your fingers, and you would follow with your eyes to the fingers, and you would repeat this twice, and you would go without moving the head, and then you would stop and you would actually reassess the symptoms, whether all four, the headaches, dizziness, fogginess, and nausea, and you would score each one individually. So saccades is where the fingers 1.5 out of, I don't know if you can see my fingers, but it's about 1.5, so it's 3 foot apart, the fingers, and you would ask the patient again to keep the head still, and it's just the eyes that move, and it moves from one side to the other. You would do 10, and sometimes you could do 15, but you do 10 movements back, forth, and then you would look at the eye tracking. You would look whether there's any skipping. You would look if there's overshooting of the eyes, and then you would also then reevaluate all the sensation, all the symptoms, headaches, dizziness, fogginess after each one that you've done. So you do 10, then you would rescore. Then you do, that's the horizontal, and then you would do the same for the vertical. So basically the same, the fingers is just up and down. You would ask the patient to bring the eyes up and down with you, and it's as fast as they can do it. It's quite important to do as fast as they can do it. If there's any symptoms in between each test, you would actually just ask them to take a little break so that you actually bring the score down. Otherwise, you get an accumulated effect within the testing. So the VOMS is 6 different tests. So this is another one. This is a horizontal VOR, vestibular ocular reflex. So examiner would hold a sheet with an A, or we use a checkerboard as midline, seated 3 foot away from the athlete, exactly the same as you've done before. You would the nose would stay centered to the page, and to start off, and then you would actually ask them to keep the eyes focused on the middle of on the A or in the middle of the page, and you would then use the head 20 degrees at a metronome of 180. So it will be this kind of movement. It's pretty fast to do that, and it's 10 reps again. So then once again, you would score headache, dizziness, fogginess, nauseousness. You would do the same there with the vertical side, also 20 degrees, 180. So it's up, down, up, down, up, down that you would do with VOR. So visual motion sensitivity, that is when a patient would stand up, they will place their arms in front of them. So this out of my way. So arms is basically forward. You have a thumb and a finger, and a patient will then swing 160 degrees, so 80 degrees to one side, 80 degrees to the other side, with the shoulders, the head, and also the trunk, everything together. You would stand behind them, make sure that they don't fall over, and then you would do 10 reps of that, and then again you would score their headaches, dizziness, fogginess, and nauseousness. After that, you would do the last two. Second last one is the accommodation that you would do. You would do that with each patient eye independently. And to do this, you use a conversion rule, which is something like this. Don't know if any of you have seen a conversion rule before, with a 14-point font. And you would basically put it on the patient's face, and you would ask them to bring it closer. And then when it gets blurry, they would stop, and you would take a measurement in centimeters for that. So normal accommodation is 10 centimeters. So anything under that is normal, anything more than that is abnormal. And you would repeat that in the other eye as well. Then you get conversions. You do that with both eyes. The same, you also use your conversion rule at 14-point font. and the patient would bring the font closer to his eyes, and when the viewing gets double is when you would then take the score. Normal would be less than or equal to 5 centimeters. Anything more than that is an abnormal score. Again, you would do all the symptoms that you would evaluate. So this is the modified SCOTE office tool. That's from the Amsterdam Convention. You will see that there are 4 tests that they would do: smooth pursuits, horizontal and vertical, saccades, horizontal only 10, and then VOR 10 repetitions. Also just horizontal, and then the motion VMS you would do only for 5 reps. There's no accommodation and there's no near point conversions that's being tested here. So in my clinical experience, I actually find that I prefer the full VOMs because I've often find that with saccades, even the vertical and also near point conversion, there's often a lot that you can pick up, especially in final rehab when unexerted state, and also especially when there are cervical issues and you add cervical torsion to the test, it really flares up a lot of symptoms, and you can see a lot of eye movements that's tracking incorrectly or over skipping, or yeah, there's just abnormalities in the eyes. So I think if if it's a time concern, the SCOTE is good, but you potentially could miss a few things if you just do the modified version, in my opinion. Okay, so I'm going to now talk about graded exercise and concussion. Now, this is a snapshot and evidence-based influence of exercise on persistent symptoms. It's one of the most well-researched topics in concussion. Aerobic exercises has been shown to improve neural function, cohort connectivity, and increase brain healing modulators in patients with persistent symptoms. Many studies have been done. Gladstone in 2019 showed aerobic exercise at 80%. The symptom threshold to be improved after 6 weeks, improves the cognitive function. Sorry, I just want to take, sorry, I'm struggling to get my, sorry guys, I just need to get, because I can't see properly on my slides. Okay. So when do we start with graded graded exercise? We basically start acute 5 days post mild TBI, and for PCAs immediately after, and at least by the second rehab consultation that we would start with that. This is just evidence to show all the exercise research that's been done. And this is, like I said, it's just a snapshot. There is so many of them, so you can familiarize yourself later with these. So just to talk about the Buffalo concussion treatment. So currently, advice is to, currently advice is to absolutely rest. Well, to absolutely rest is not advised anymore. It's not the best approach at all anymore. So no more dark rooms and no screens and taking 2 weeks off. Many sports bodies still have this as their concussion protocol, as well as return to sport once symptoms free, which I don't think is best practice at this stage. So familiarize yourself with the new rules and regulations. So what do we advise? We advise 2 to 3 days of active rest. So like I said, no lying down. They are allowed to move around. They're allowed to go and walk around. They can even be using screens, but it is all symptom driven. So as long as it doesn't make these symptoms worse. And after 2 to 3 days, we start pushing back into cognitive and physical activities. There's lots of research done. Thomas et al., John Leddy has been doing quite a lot of studies to show that there's a lot of you can actually increase your recovery rate by including exercise within concussion rehab. So we all know that exercise influence more than just blood flow. with suffering a concussion, it's known that there is an autonomic dysregulation that leads to deactivation of the parasympathetic nervous system and an increased activation or overdrive of the sympathetic nervous system. This imbalance can lead to systemic issues like blood flow impairment, digestive issues, increased anxiety and stress, sleep disturbances, hormonal imbalances, and cognitive problems. Physical exercise as a subsymptom exercise prescription in concussion has been shown to be one of the best ways to rebalance the autonomic nervous system, and especially in patients with persistent or prolonged symptoms. Exercise and specific the Buffalo Concussion Treadmill Test is one of the ways we as CCMI clinicians manage and introduce as part of our rehab protocol. So when do we use the Buffalo Concussion? So acutely, day 5 to 7, it's preferable. This is also return to non-contact activity when they pass the Buffalo Concussion Treadmill. If they fail it, then they stay within symptom progress, graded exercise protocol with subsymptom thresholds that you would provide them with to exercise. It accesses physical readiness for activity and initiate early exercise rehab. Chronic symptoms, we basically start managing people with symptoms from day 7 to 10, as if they are developing a PCS. And this we do with establishing an exercise threshold for rehab. The protocol differs slightly for both acute and chronic phase, and the Buffalo Concussion is the only functional test shown to diagnose safely and reliably a physiological dysfunction in concussion. So what is the intention? It's basically to provoke athlete's symptoms to some degree, and this will then be the guide that you use to exercise your individual patient at the correct level. And what we find is that if you work, let's say someone fails the symptoms at, let's say, 130 heart rate, in other words, it's all symptom driven, so some of the symptoms go up. You would stop them there and you would prescribe them 80% of a rehab level. So the rehab aim is really to rehab their autonomic dysregulation, which is one of the 5 main drivers, like Dr. Jim has basically just showed us on his screen, on his slides, within the PCS findings. It also provides a way to establish what level of exercise is safe for the athlete to exercise at in the recovery phase. So acute phase, day 5 to 7, you would, when they go onto the Buffalo Concussion Treadmill Test, if there's any increase of overall symptoms, that will be a fail. So you would then take their heart rate and you would begin a symptomatic threshold exercise, 80 to 90%, depending on whether it's an elite athlete, you would start at 90% for 20 to 30 minutes per day for a whole week, and then you would retest and you would build up slowly till you get to till they can basically pass the Buffalo Concussion Treadmill Test. Once they can do that, they can begin with non-contact exercise protocol. So the chronic phase, we retest, we start normally day 7 to 10, like I've said, or if you see someone down the line 2 or 3 months after they've actually suffered a concussion and they're in PCS, we try to see them at least by the second time that we see them to prescribe an exercise program for them. Okay. Okay, so how do you do this? You basically take a resting heart rate at baseline level after 2 minutes rest, take a baseline overall concussion score, a condition score. I don't know if you know what it looks like. It's a little one with little happy faces, or then as they go on, it gets actually out of 0 to 10. Then the Borg scale is important to have, 6 to 20. So you take all of these scores before you actually you start your Buffalo Concussion Test. And you continue to increase the level of exercise. Firstly, we start with increasing the gradient that they work against, and over time, when they reach a gradient of 15 degrees, we will then start increasing the speed. Every minute you would take their heart rate, and you would take their Borg scale and their overall condition score. So, and then you would follow the protocol as in the previous slide as to who's failing and who's passing going forward. So with the Buffalo concussion treadmill test, there are some contraindications. If you do plan on doing the Buffalo concussion treadmill, please make sure that you know about these contraindications before you put someone on the treadmill and start evaluating them according to that. So this is a algorithm for PCS patients that we follow within the in my clinic. So you can see at visit 2, you would do the Buffalo concussion treadmill test then, which is then followed up with a VARMS test at visit 3. So there's normally a 1 to 2 weeks in between these two. So first consultation, you would definitely you would see them. Sometimes I would do a Buffalo concussion test already at the first visit, depending on you know, at what stage they are, how much they can do at that point. You don't want to, you know, overexert them, but also it's more important to actually get them onto a physical exercise program so that they can start improving, especially when you have people that's starting to physically become unfit and yeah, they're not making any progression. So I just want to show you this. This is a case study from one of my patients and a little bit of the discussion on the VARMS and the Buffalo concussion treadmill test. So I had a young adolescent football player at age 14. His initial injury was in the beginning of January, and his first consultation was about 6 weeks later. The duration treatment was 4 weeks. His final exertion test was 2 weeks after that. That was the Blackhawks test. So the working diagnosis was post-concussion syndrome, and the drivers were physiological PCS, servogenic PCS, and vestibular ocular PCS. What history? He basically dived into a goalpost, right side of the crown, and anterior-occiput, where he had the impact. He had immediate dizziness for a few minutes and no LOC or headaches, I suffered headaches. He didn't go to school for 3 days and then returned to school to a full day. No PE, no sport, and the athlete had a SCAT test, which he failed after the initial concussion. So neurologic examination, he was normal. There was nothing, no red flags there. And then cervical spine examination, there was a lot of positive soft tissue findings. And this also, when tested and including the cervical spine within the VARMS by cervical torsion test, it actually made the VARMS test much more positive, which I will show you in a minute, the findings that I got there. So visual tracking, positive findings, mainly accommodation over conversions. So he was 14 years old. He didn't wear any reading glasses but his accommodation was 13 and 11, and normal is 10. And the VARMS eye tracking deteriorated during the test, and some abnormalities were seen while he did that. So symptoms at first appointments was headaches, dizziness was the main complaint. And then he also had, interestingly, when he changes from sit to stand, turn in a bed and bend over, which originally made me think that it could be vestibular side of things, but we've tested him BPPV and there was no issues there. He tested normal, and it turned out that it was mainly cervical driven, where the symptoms were coming from. So the initial score that he had, it was 12 out of 22 symptoms, and severity was 28 out of 132. So yeah, so he would suffer one of his main complaints was dizziness, especially when he went to school, and he would be reading a lot, or he would be sitting in class. He would find that he would suffer a lot with dizziness and blurred vision. So the VOMS findings, I know these are really small. You might not be able to see what I've written there, but once the slides are shared, maybe you can see, then it will make more sense to you. But his saccades, horizontal and vertical, was really difficult to do. His eyes struggled to follow my fingers and would develop headaches during the testing. His speed was also really low, and much reduced the rhythm. He just couldn't keep up with the fingers, and kept on missing. So the VOR, horizontal and vertical, were both affected and couldn't stay with a beat, the 180 beats per minute, and his eyes lost focus. So with the visual motor sensitivity also deteriorated. Thumb focus, he seemed to have blurred into the background, so he didn't keep his focus on his eyes, but this also improved over the next 4 weeks. So accommodation originally between 16 and 18 centimeters. This has improved hugely, but already by the second session. I will tell you a little bit more what we've done other than VOMS and buffalo concussion, which helps us because it's a multimodal treatment plan. It's not only just 1 or 2 tests, like I've said before, that you would do to actually help these guys. Then the abnormal near point conversion. At the first consultation was 15.5 centimeters, and by the second it was 9 centimeters. So that's still outside of the normal range, but there's a huge difference just from 1 week to the next week in giving them specific exercises and looking at their diets and that kind of thing. So during the 4-week rehab period for cervical torsion was added. So they were, and we find that we modified his school attendance, which was implemented for the 3 weeks. So he would, for example, would start with a 30-minute class session because he would get dizziness around 30 minutes. So we would do, or 40 minutes. Then we would do a 30-minute class session with a 5 to 10-minute break. He doesn't always have to leave the class. He can just sit in the class, and he can then just not focus on anything. He can play soft music. So he can play music, or he can just lie on his arms, and then he would rejoin the class for next 30 minutes. So when the symptoms then reoccur, then he would go and he would have a 15-minute break. So eventually we started building up on this until he was able to do a full hour to an hour and a half in a class. And that took him about 4 weeks to get to that point. Then the additional treatments and managements that I've managed with him. We did a lot of work on cervical soft tissue management, not myself, as well as his club physios. Dietary recommendations were made to reduce systemic inflammation, and he responded really well. And then he was recommended to do 3 to 4 times per week a DANOC on cognitive exercise testing, which is coming from a little app that I will share with you. And then he also did vestibular ocular rehab exercises that we would give him, and we would progress that from just basically working, sitting down and having eye functions, into walking with his head moving, while he's walking. And then we also looked at his sleep management, because he had some issues with sleeping. He couldn't sleep, he couldn't fall asleep. Which we gave him some breathing exercises. We've done some tapping with him. So that seemed to have really resolved as well within 4 weeks. I did consider by the end of 4 weeks to refer him for a neuro-optometrist, because there were still some VOMS findings within his cervical torsion testing, but that cleared up before I see him for his before the Black Hawks test, which was 2 weeks later, and he was fine by then. So there was no need for that. So initially, he failed the buffalo concussion. This is the same patient. He failed his buffalo concussion treadmill test at 115 beats per minute, heart rate. So we then started a graded and steady state heart rate physical training program at 80% of that current heart rate failure of that session of 115. And then slowly increased it every week. We would up that, and he would actually perform better every week until he was able to pass the Buffalo on his fourth session. He passed the Buffalo concussion treadmill test. So again, he was then allowed to return to specific sports activities, but not any contact at that point. And then he was at that stage at full days for school restriction. So good to know that you don't have to clear, each one is independent, school return and also sport return and the Buffalo concussion test. But before you actually would pass them or clear them fully for return to sport, they have to be fine with all of these. They have to, all of the symptoms of VOMs and all of your tests should have passed that by the end before you can actually start doing a Black Hawk's test. I don't know if you know what a Black Hawk's test is. It's exertion testing that you do with clearance for return to sport. It's normally only done for the elite athlete, and it's quite exerting. We also have one for children, which is an amended one. It includes various different phases, starting one on a static bike, and then you would do plyometric exercises with them, and then you would put them through a typical baseline testing, and you would do once they've done that in the exerted state. So it's pretty full on. So once they've passed that, then from my point of view, the clinic then clears the athlete and then send them or return them back to the sports physician for final clearance and return back to sport. So just to share this with you, one of the things, especially because I think there's a few clubs and sports coaches on the call tonight. We have a concussion tracker app, which is available on Android and also on Apple. It's free to download, and it really gives us it really brings everyone together. It brings the athlete in the middle, and then everyone else involved around them can then tap into their recovery and how they're doing. And how they progress as well. It offers various different solutions. It has a SCAT-6 on it, which you can then use. As you know, it's actually a sideline test, and it's valid for 72 hours. It brings all the key stakeholders together that's involved with the athlete. It creates a clinical network and offers software. It's a neurocognitive postural. It has all of neurocognitive testing, which is a free one. And you can also use this, especially with the physios on the call. You can use that to actually give it to as a tool to your patient and part of rehab. It has a postural sway in now, and it also does visual tracking. So there's a lot that it offers, and it's really worth maybe looking into this. You can also create teams for yourself, especially when you're a coach. And then if any of them actually has a concussion, you will be able to track when they're back to return to sport. You can also check all their baselines, or make sure that your whole team actually does have a baseline. A baseline, just to recap on that, is still at this point the best way forward. And the best way to prevent, to help us with bringing patients back to in rehab and actually achieve the best outcome for everyone, because then you have something to work against. At the moment, if you don't have a baseline test, basically it's still a clearance that's made on basically on a patient's risk or the athlete's risk, because you have nothing to compare it with. You don't know where they were before they suffered the concussion. So baseline, I can't actually stress how important it is that clubs start implementing baseline tests annually for their players.
Martha, so sorry to interrupt. I'm just
No,
conscious
go for it.
of time, but I think you're on the last slide anyway.
I am. I'm done. Can you hear me?
Yes.
Okay. So yeah, I think, have I gone over my time?
You have, but not to worry.
Okay. So anyway, I'm done. Thank you very much. Just once again, I just want to say thank you for having me, and and making this possible, and all the CCMI as well, all the hours and hours of evidence training that I had with them, and for being here tonight.
Thanks, Martha. Thanks very much for that talk and insight into all those aspects, which are, I'm sure, new to a lot of people here. If you could stop sharing, I'll start sharing my presentation. Thanks.
Okay. I can't seem to get my mouse to work. That was the problem. Hang on. Oh, there we go. Got it. Sorry, there we go.
Yeah, thank you. Thanks, Martha, again for that talk, and to Jim also. So I'm going to talk briefly. I appreciate it's coming up to 8 o'clock and people will want to get some dinner and stuff. So I'll try and make this fairly brief, and we can hopefully have time to answer a few questions. But I'm going to talk about later in life risks following sports-related concussion and retirement following sports-related concussion. The objectives are to understand the current evidence behind later in life risks associated with sports-related concussion and repeated head injuries, and understand when we might consider retirement from contact sports following sports-related concussion. This is a very topical area. This was from the BBC Sport website in July last year. Former England hooker Steve Thompson saying that he would donate his brain to scientists researching CTE. This followed a publication from Chris Nowinski and colleagues on the possible causation from repeated head impacts and chronic traumatic encephalopathy. There's been various other high-profile cases in the media. Keith Ponton, who died of dementia, that was felt to be due to head trauma following the coroner's report. He was a former Cardiff and Wales defender. And Willie Stewart, who you may have heard of, who's a neuropathologist in Glasgow, said that the overwhelming pathology when he examined his brain tissue was of chronic traumatic encephalopathy. The FA have produced guidelines for underage players, from under 11 through to under 18, about heading frequency based on the concerns that repeated headers. So I've got two sons who play football, and I've got an 8-year-old who loves heading the ball, but I encourage him at every training session not to do that. And I know the coaches are quite switched on to that. But you can see here in this flow chart that as you get up towards under 18 level, although heading remains a low priority, there are more headers in training. Historically, CTE was seen in boxers. This was described as long as 100 years ago, and phrases like punch-drunk dementia pugilistica and traumatic encephalopathy of pugilists have been used over the last 100 years to describe the features that boxers can develop later in life. And this is Tommy Flanagan, a Manchester-based boxer who was diagnosed with dementia after a life in the ring. So what is CTE? Well, repetitive brain trauma is thought to be associated with progressive neurological deterioration. And you can see the slides on the right of brain tissue, and below the actual big slides of brain tissue, you've got the microscopic histopathology. It causes mood and behavioral changes, memory loss, cognitive impairment, and dementia. And it can be diagnosed by neuropathological examination of brain tissue, looking for what are called p-tau aggregates in the neurons. This is the relevant publication, which is freely accessible online, and I would encourage you to read it. It examines the later in life health risks associated with sports-related concussion and repetitive head impacts. It's a systematic review. There's a huge amount of work has gone into pulling together this information and narrowing it down to these 28 studies. 10 of which are in former amateur athletes, 18 in former pro athletes. Interestingly, they did not include post-mortem neuropathology or neuroimaging studies because they were not case-controlled or cohort studies. And as a result of that, they were felt that they could not accurately examine risk. What are the main concerns with later in life health risks? Well, it's mainly cognitive impairment, mental health problems, and neurological diseases. There were two primary exposure variables looked at in this systematic review, and that was sports-related concussion and exposure to repetitive head injury impacts. And they looked at sort of number of years playing football or rugby, and also the player position. And what are the sort of outcomes that were looked at in this systematic review? Well, they looked at depression and suicide, Alzheimer's and other forms of dementia, Parkinson's, ALS or amyotrophic lateral sclerosis, which is a bit like motor neuron disease, and cognitive decline. Other things that were of interest are quantifiable changes in the brain structure, physiology, or biochemistry, accumulation of pathological protein surrogates using PET scans, and then pathological protein aggregates after death using immunohistochemistry. This is the headline from that systematic review. So in depression, with regards to depression, 5 studies in amateur athletes showed no increased risk. In terms of suicidality, there was no association with increased risk in amateur or professional players. And there was no evidence of increased mental health or neurological diseases in former amateur athletes with exposure to repetitive head impacts. But there was some studies in former pro athletes suggesting an increased risk of neurological disorders such as ALS and dementia. But throughout this systematic review, it talks about the risk of bias and confounding factors. So, if players have had a lot of musculoskeletal problems and they're on various pain medications, that might affect their cognitive function. It might affect their mental health. And just because there is lack of evidence doesn't mean that there is lack of effect. So we need to keep in mind that there's a need for higher quality studies. Moving on to when should an athlete retire or discontinue participation in contact or collision sports following sports-related concussion? Well, here's the headlines. If there are persisting or prolonged symptoms after concussion, neurological abnormalities and physical examination, deficits on neuropsychological testing despite having taken time away from contact or collision sports, increased symptom severity and/or duration with repeated concussions, concussions precipitated by lower threshold impacts, and structural abnormalities identified on conventional neuroimaging that may be associated with an increased risk of poor outcomes with future head impact and require neurosurgical assessment. So I'll just finish with a case study. I've changed the details slightly. This is with the player's consent. So semi-professional footballer, central defender, university degree, and works as a primary school teacher. Presented to me with a head injury 5 weeks ago, got a hit to the chin 15 minutes into the match, but continued playing until half-time. The impact, he said, was lower than what would usually cause problems, and he continued playing until half-time. In terms of symptoms, he had 17 out of 22 symptoms and a symptom severity score of 50 out of 132. As Jim mentioned earlier, symptom number and severity, particularly with prolonged symptoms this far down the line, indicates quite a poor prognosis at this stage, and the likelihood that it's going to take a long time for him to get better with this sort of symptom severity so far down the line. In terms of his concussion history, he's had 10 concussions throughout his career, and the last 2 were quite significant ones where it took 3 to 4 weeks for him to recover. And he had also described a severe concussion at the age of 14 with loss of consciousness and amnesia for a few hours. He was otherwise well, no medications, no history of any other sort of features that might put him at risk of prolonged concussion symptoms. We use this, as Jim mentioned, the NIH Toolbox, which is a cognitive battery of tests, which looks at things like short-term memory, vocabulary, processing speed, and concentration. And here's the relevant section. In this particular player, we did not have a baseline to compare against, but this test takes into account the average for that individual given their educational attainment. So given that he'd gone to university, there's an average score which we would expect him to attain. And we look at the age-corrected standard score, and the average would be 100. So you can see if you look down this yellow column, he scores above 100 on the pattern comparison processing speed, which in my experience is probably the most sensitive test for concussion. But all the other domains were well below what you would expect for a teacher. Examination-wise, in terms of autonomic nervous system, his pulse and blood pressure were normal, both with lying down and after standing for 1 minute. There was no postural drop or no tachycardia and no increased symptoms in standing, so no concern about autonomic dysregulation. His cervical spine examination was completely normal. Neurological examination was completely normal. Fundoscopy was normal. His balance, modified BESS, he scored 5 errors. Dual tandem gait, he had normal dual task tandem gait. So we do that, as you may know, with subtracting serial 7s from 100 to try and distract the person who's doing the test whenever they're doing a physical test, and it just makes it more difficult and draws out any abnormalities. In terms of mental health, his anxiety screen indicated mild anxiety. His depression screen was low, but there was some suspicion for mild depression, and his sleep screen was normal. So initial management, I asked Martha to see him with a view to further VOMS assessment and a graded exercise test. I referred him for an MRI scan of his head based on the number of concussions that he previously had. I advised him about exercise and advised him to walk only for now, to take 3 weeks off work. It was coming up to the Easter holidays, and then to commence a phased return and to avoid driving for the time being. Also discussed avoiding alcohol, optimal sleep and sleep hygiene advice, optimize his nutrition and hydration. Just on that point, nutritionally, we encourage people who've had concussion to take fruit and vegetables because of their polyphenol and flavonoid content, which have antioxidants, and there's a lot of oxidative stress following concussion, so those fruit and veg can be particularly helpful. Also, optimal hydration we know is good for brain health, and omega-3 supplementation at 1,000 milligrams daily, particularly the DHA type of fatty acid, is particularly useful for its anti-inflammatory properties in following concussion. This is an MRI scan of his head. So we use very sensitive sequences, which are called diffusion-weighted imaging, and SWI sequences, which look for micro hemorrhages. And we're looking for any subtle abnormalities that might give an indication that he is at risk if he returns to doing a contact sport. But his MRI scan was reported by my colleague Rob McCreary, who said it was completely normal. I reviewed him at 1 month. He had a marked improvement and he was coping well at work. He only had 4 symptoms on review, and he was doing walking and resistance exercise symptom-free. His repeat cognition tests, you can see on the right-hand slide, part of the slide here, he's improved markedly. So apart from his vocabulary test, his cognitive scores had improved a lot. The picture sequence memory test was still down, but had improved markedly compared to his previous test. Again, we don't have a baseline to compare against. In view of his ongoing fatigue symptoms, I also arranged for him to have some blood tests, looking at pituitary function and looking at some other things that may sometimes contribute to fatigue. And these were all normal, including his cortisol and testosterone levels. So a summary of this particular case, central defender presents with a high number of previous concussions and some with prolonged symptoms, prolonged symptom number and severity following his most recent injury, and a lower degree of impact, concerningly, which resulted in this injury, and he continued to have mild symptoms. So he's not a player who you would want to put back into contact sport at this point in time. And the next conversation that came up that the player brought up was, do you think I should continue to play football? And, you know, what are your views on retirement? And there was somebody with him, his partner was with him in the consultation, and that's a complex question to answer. And we think about benefits and risks. Obviously, there's a lot of benefits from continuing to play contact sports. You know, the enjoyment, it's part of the player's identity. His social life revolved around the club. He's semi-professional, so he gets paid for it. I see professional players as well who you know, they rely on their income. And in terms of risks, there are risks which are difficult to quantify. So the long-term risk of cognitive problems, mental health problems, dementia are really difficult. And it's important that we explain that it's hard for us to predict that at this point in time because of where the evidence is. And probably the highest risk to this player was of having a further concussion and having prolonged symptoms following a further concussion. So we talk about shared decision-making in these sort of instances, and it needs to be individualized and a collaborative approach, both with the player and with the coaching staff. And it's important to highlight the benefits of physical activity. We know that physical activity is very important for physical and mental health and cognitive health. So whenever, we're advising about maybe taking some time out from contact sport, it's not taking time out from all physical activity. It's actually very important to encourage other non-contact forms of sport. And in this case, we discussed considering non-contact sport for a prolonged period before making any final decisions about returning to a sport where there's a high risk as a central defender of further injury. So, for example, taking one season out. It's important that we incorporate the athlete's preferences and what their attitude is towards risk. Some athletes have a very low tolerance towards risk and some very high. And, ultimately, if the athlete has capacity, it's their decision, it's their autonomy to make that decision. And as healthcare professionals, it's our job, I feel, to give them the best information that we possibly can to make the best decision and make sure that we give them that information, at a time when they're ready to receive it, and making sure that they've got capacity to make a good informed decision. So that's a rapid run through of problems that can occur later in life, and some of the issues around that come up around retirement. I appreciate you all coming this evening to listen, and there will be some feedback forms which will come through, and a CPD certificate.